am now.
Okay, great. Mason, go ahead and
Great.
start telling the story, and let's start filling things out.
And just so you guys know, this is not the BMP we're starting with. Just to give me somewhere to remember to put all the numbers.
Right. So we've got a 65-year-old gentleman being admitted from clinic with abdominal pain. And then why don't we just leave that there and go ahead and give you his labs. So sodium 137, potassium's 4.2, chloride's 102, bicarb 29, BUN's 21, creatinine's 2.4, glucose is 108 is fine. You know, I didn't write it down. And then let me give you a little bit more, and that his calcium, let me give you his calcium. Which is 15.9. So let's say we get this patient, this is all we know about him. What do we want to ask this patient about?
Sukriti, until Austin takes care of her dog, you're it. And FB, you back? FB's answering a page. So we'll just let you talk for a while, and then I'll I can help, because I know the patient, but I don't know this part of the case.
Right.
So immediately when I look at this information, what jumps out is his calcium and his creatinine. But taking a step back and thinking about who this patient is, so he's an elderly male with complaints of abdominal pain. And so abdominal pain, I'm not sure where he's having pain or if it's diffused or localized. But layering on the labs, the creatinine suggests some sort of renal pathology, and this would affect how the parathyroid hormone acts on the renal tubules, and how vitamin D is metabolized to create the active metabolite that would affect the gastrointestinal reabsorption of calcium. And what's most concerning here is this patient's calcium level of 15.9. I'd also be curious what his albumin level is, and whether this is his ionized calcium, whether we could get maybe an ionized calcium.
Yeah.
Okay.
Go ahead.
That's a great start. Do you have some of that, Mason?
Yes, I do. We can start with this. Albumin is 3.9. Ionized calcium was 2.
And normal of ionized calcium is 1 point something. I know that.
Yeah, I actually didn't write down the normal. I think it's about 1.5.
Okay, so I'm gonna ask. I'm gonna suggest we reframe this.
Go ahead.
So a calcium of essentially 16 is really unusual. Normal calcium is somewhere in the 8.5 to 10.2 range. This is an extraordinarily high calcium. Extraordinarily high calcium has a different differential than modestly high. This is not someone who you work up in clinic. This is someone that you admit. So what I want y'all to think about is, what's the classic patient presentation? Because we can ask some questions and see whether or not he has the classic presentation of a calcium of 16. And then what we need to do is figure out what is the differential diagnosis of a calcium of 16, which is different than the general differential of hypercalcemia. So is Austin back yet? Still dogging.
Okay, wait, no, I'm okay.
You're back. Hey, Austin.
Yes.
Okay.
No, mentally I'm like 80%, but I am physically here.
Okay. So we have this calcium of 16. What would you expect the patient to complain of if they have a calcium of 16?
This should be a very easy question.
Well, it's actually a hard question unless you've actually had a patient with this and thought through it, because you don't see it very often. But
Yeah,
when you
no.
see it, good. So this is a classic morning report case. This is a classic morning report case. And so knowing what the impact on the body is of a calcium of 16 will help you a great deal. And then we can go through the differential. So FB, are you around? The ER is bothering FB. Okay. So is there anybody, let's see what the chat is saying. Maybe the chat can help us.
Yeah, it looks like the chat has a lot of good questions that I can answer about the history that's presented. Someone asked if this patient has altered mental status. And yes, he does. He's been endorsed confusion over the past several days, even having some possible visual hallucinations, just seeing a cloud go across the room and that sort of thing. And this has been worsening over the past several days.
Kushal was very smart. I already knew that. So mental status is one of the things.
Right. And then I see someone else. Yeah, you mentioned Kushal mentioning confusion and then constipation. Yes, this gentleman said last bowel movement was a couple days ago, but before that it had been 4 or 5 days and is constipated. And then also, yes, polyuria, another good question for this guy. He says he's been urinating very frequently, going 12 times a day, and then also feeling thirsty a lot and drinking a lot of water.
And this is actually the classic triad of severe hypercalcemia. Okay, so the fact that y'all didn't know this means this is really worthwhile for us to be teaching you, because somebody's going to ask you this again in the future. And one of these days you're going to take a history from someone and get this history, and before the calcium comes back, you know what it is. So the question is why the polyuria? So the constipation is a direct effect of the calcium. The confusion, it has to do with the calcium. How does the calcium cause polyuria? Kushal knows the answer, but I'm not going to. But he's too smart. Do y'all have any idea? Okay, Kushal.
Uncle Bob.
Yeah.
Can I take a guess?
Okay, you can guess.
There's a calcium sodium exchanger in the distal convoluted tubule. Does it have to do with the sodium in the renal tubule? And
God, that's a really good guess. It's wrong, but it was really good thinking, and I'm glad that you know that physiology.
But they did talk about this on the Kirk titers. They had a whole thing. It's the very convoluted mechanism about how it like decreases the gradient because you don't have the calcium pushing like the sodium or the potassium somewhere.
It's actually it's actually simpler than that. So it attaches to aquaporin 2 and prevents ADH from attaching to aquaporin 2. And as soon as you lower the calcium, the polyuria goes away. This is the big cause of nephrogenic diabetes insipidus. And it has to do with that. Okay, so his presentation is classic. Because of the polyuria, you often get what looks like acute kidney injury. And I've written up a couple of cases of hypercalcemia, and they always come in with high BUNs and creatinines, and then you lower the calcium and the BUN and creatinine get better. So it's not nephrotoxicity, it's just severe volume contraction. Okay. But let's get back to the differential, and so I'm going to let Fernand help you with the differential. But why don't the two of you see if you can come up with reasons that someone will present to the hospital with a calcium of 16? And there are three big reasons.
I feel like the dogma is always like outpatient, it's primary hyperparathyroidism, and inpatient it's malignancy.
So malignancy is 100% right, Austin. That's great. Hyperparathyroidism can present like this if it's undiagnosed. And the third one, somebody actually did mention in the chat, and I've seen this 2 or 3 times.
Milk alkali.
Milk alkali. Do you know why it's called milk alkali?
Because people used to drink milk as an alkaline buffer for the acid in the stomach instead of the nowadays Tums, basically.
So it was actually, there was a diet called the Sippy diet, named after a surgeon called Dr. Sippy. Number 3 is hyperparathyroidism, Lindsay. You will occasionally have someone admitted with hyperparathyroidism with a calcium that high if they're undiagnosed. And anyway, so this is when we thought acid had everything to do with ulcers, and his diet was a lot of dairy in 6 small feedings a day and a lot of sodium bicarbonate. And that's why it's called milk alkali. People were thinner then, so there wasn't as much reflux. Now we've seen milk alkali with self-treating reflux. I've seen it with a patient who just liked the taste of Tums and ate them like candy. There was a period of time about 15 years ago when women were encouraged to take extra calcium to protect their bones until we found out it hurt their heart. And so you'd see women come in who were taking big doses of calcium as a preventive measure. That's not done anymore. That was a mistake. But that's the way it was. Now, malignancy is interesting. And I'm going to let Fernand work with the two of you to try to figure out the 4 different ways that malignancies can cause hypercalcemia, while I shut the door to my room so I don't hear all the noise in the other part of the house.
Yeah, I would think about it as direct effect of malignancy in its proximity and in its surroundings, basically, and remote effects of malignancy via different mechanisms. So
Fernand, we're just supposed to work with Sukriti and Austin and see if they can see what they say, and then you're going to teach them. So this is preparing you for internship. I promise you're going to be asked this during internship. This is really good. Mason, I'm not exaggerating, am I?
No, you're not.
You'll hear this over and over and over again. Because these patients get admitted when they have if you have a calcium of 16, you're getting admitted. So there are 4 different ways. So Sukriti, do you have any idea how malignancy would cause hypercalcemia?
Building off what Fernand said, one of the mechanisms could be the production of alpha hydroxylase. I'm sorry, the PTH-related peptide, which then acts on the PTH receptors and causes hyperparathyroidism. The other could be an
let's stop with that one. What's the classic tumor that does that?
I know lymphoma. Lymphoma might do that, but I'm not sure what the classic one is.
Austin, do you remember?
Like squamous cell things.
That
maybe?
Squamous cell thing. Yeah, especially squamous cell of the lung, right? Do you ever see that, Fernand?
Yeah, actually, I just got called by the AD on a patient who has squamous cell carcinoma of the larynx. His calcium is 15.6, and I can bet $1,000 that his PTHRP is super high, but we don't measure it.
You don't even measure it?
It's some people just order it. We don't do it routinely just because I'm very conservative medically, and it's not going to change our management. And it comes back a few days later. So sometimes you might see it in charts, but I would personally not send it except if we're doing some research.
But that's if you know they have squamous cell. If someone came in and there was nothing obvious, you might send it as part of your wild goose chase, because you have to figure out what it is. Okay, so that's number one. Okay, Austin, do you have another one?
I think with bone metastasis, the osteoclastic reabsorption causes more.
Okay, so what would be classic ones like that?
Breast.
I think breast would do that. Yeah. Fernand, when do you see this?
Yeah, very common in breast, very common in another cancer. Technically, all the common cancers, you probably can guess them, can cause this. And there's also thyroid cancer on the side. Can you guess the other two common cancers that can cause this? Bone mats?
Yeah, two other cancers that cause bone
Because
mets.
it's specifically osteoclastic ones, right? With osteoblastic ones, that wouldn't make sense to cause hypercalcemia.
Yes, exactly. They should be osteoclastic. What are the two most very, very common cancers that go to the bone and can lead to erosion of the bone?
The colon cancer.
I'm sorry, I didn't hear that.
Colon cancer.
It's possible it's not as common as the other two.
Lung cancer?
Lung cancer, definitely.
Just playing a numbers game.
Yeah. Even your most common form, which is adenocarcinoma, goes very, very frequently to the bone and causes mets. It's very commonly seen in newly diagnosed metastatic lung cancer. The other one is something mentioned in the chat, which can cause both osteoclastic and osteoblastic lesions and generally affects the lumbar spine. Do you know what cancer this is?
Prostate?
Yes.
Oh!
Yeah, it can cause a mixture of osteoblastic and osteoclastic metastases. And it starts in the lumbar spine. So if you have an old man with lumbar spine metastases, pain that's inflammatory, that's not going away, think prostate cancer before you think about something else. And it's basically because the prostate area is drained by venous plexuses that go to the bone in the lumbar spine before going somewhere else.
Okay, so that's two down. Now we have a disease that's famous for hypercalcemia and for kidney disease. It is a malignancy. We might get a clue when we get a CBC. We might have a few other tests. It starts with an M.
Wait, Sukriti said it.
What did you say, Sukriti?
Multiple myeloma.
Right, multiple myeloma. And how does that cause hypercalcemia?
Um,
Oh.
Good. That's why we have Fernand here to explain it to you.
So where do cells, the plasma cells, proliferate? Inside the bone marrow, basically. So they do not live alone. They live in a stroma and an environment, and they're not inert cells. They secrete cytokines. So they secrete interleukins and some bone modifying agents that interact with the osteoblasts and activate the balance in favor of osteoclasts, and they basically erode the bone, but not with PTHRP mechanism, through this local change in the environment. That's how myeloma interacts with its stroma and leads to hypercalcemia. And I've actually seen a case today with creatinine of 6.0 and a calcium of 12, and the patient had like a lot of myeloma.
So back in the old days, we used to call it osteoclastic activating factor, and now it's which interleukin is it? Which number is the main one?
I'm not sure on top of my head, but I know that interleukin-1 has a role in this in the local environment.
Does anybody else remember what they used to call osteoclastic activating factor? It's one of the particular interleukins. Probably that's just a pimp question. And then there's one more way that you can get hypercalcemia that's totally different than these three. And you actually
mentioned it before.
You actually started to mention it, and then you backed away. So what did you start to mention? You're saying something about hydroxylase or something. Was that you, Sukriti?
The lymphoma, Uncle Bob.
From lymphoma. Right. So lymphomas are much like granulomatous diseases. Right. So it's the same mechanism as, if you go and look at the schema for hypercalcemia on Clinical Problem Solver's website, you'll see that they have 1-alpha hydroxylase and they have a list of granulomatous diseases. And I've seen it with sarcoid. I've seen it with TB. I know it's been seen with histo and blasto, and it can definitely be seen with lymphoma. And that we had a case that we actually wrote up in that got published in the New England Journal of Medicine Clinical Problem Solver section of a guy who came in looking just like this. We treated his hypercalcemia. He got better. His renal function got better. He was supposed to come back in to check. They had checked a PTH-RP, which was normal, a PTH that was low, and they checked a thyroid level, because you can get hypercalcemia from thyroid, usually not at this high level. And then they sent off the right test for this. So what would be the right test if you suspected this? And this guy's lymphoma was diagnosed because he came in with hypercalcemia. So what test would make you look for a lymphoma? So we know the mechanism, right? We're stimulating 1-alpha hydroxylase. If we stimulate 1-alpha hydroxylase, what do we get?
125 dihydroxyvitamin D.
Right. So I don't know what it's like in Bangalore, but at the VA hospital, if you order a vitamin D level, you get a 25 vitamin D level, unless you say 125. And so if this is in your differential, this is like if you're thinking about sarcoid, or you're thinking about hypercalcemia of TB, you actually have to order the 125 to document that. Have you seen that much, Fernand?
Not really. I've seen a lot of lymphomas. Never seen it, as far as I know, as I can remember.
Okay, so we'll get to why his calcium is high, but now we got to figure out what to do about his calcium. So this guy is peeing all over the place, but he's not pooping, and he's confused about it. And I guess I'd be confused too if I'm peeing like crazy and I'm not pooping. So what do you want to do about his calcium, Austin?
I think the first step is a lot of fluids, but also like check his volume status to make sure he's not like, I don't know, in heart failure or something.
Okay. So a lot of fluids. Is that going to be enough for a calcium of almost 16?
Oh, no.
So how are we going to get it? How are we going to get it down fast?
I think it's a fluids and diuretic combo.
Okay, is that going to be good enough for Fernand?
Probably not. I expected to decrease it by maybe 2 points, but that's probably not a long-term solution, and it's not going to be enough. I would not use diuretics initially because the patient is more on the alkalotic side,
Mm-hmm.
and this can enhance the dehydration. I would just use fluids, and if patient has a poor cardiac reserve or they're starting to get overloaded, then I would add a little bit of diuretics. I've never felt that adding Lasix does a lot for hypercalcemia, to be honest.
Yeah, it's a great theory because we know that the loop diuretics cause you to lose calcium, but that's probably not enough. So this patient's pretty sick, coming in with the calcium of 16. So we have to think about what can we give him that over the next day or two is going to lower his calcium.
I want something to bind to the calcium, but I don't know what that is.
Okay, good. Listen, I think learning is about to occur. This is why we're presenting this case. So on your service, Fernand, what do y'all use?
So I just did it 30 minutes ago over the phone. We generally use bisphosphonates, which is the mainstay of treatment of hypercalcemia. Two agents that we tend to use are pamidronate, or the more expensive zoledronate or zoledronic acid. The major difference is that zoledronic acid is given over 15 minutes versus at least 2 hours for pamidronate, but it's 10 times more expensive. There are some studies that say that zoledronic acid is more potent, but they are flawed studies. Some people say they have the same potency, but you might lean more towards zoledronate if you don't have a problem with payment, and if you have a really massive and difficult to treat hypercalcemia.
So let's go back to Mason. Mason, what did y'all actually do when the patient came in?
So we did a lot of this. So we started him on fluids, with the goal being getting good urine output to flush out the calcium. We didn't do any diuretics. He was obviously peeing well and euvolemic. We held off on the bisphosphonates because of his renal function, and we were concerned some about renal clearance. And then what we also did was give him calcitonin to help us in the short term decrease this calcium, though that wasn't going to long-actingly change his calcium. It, in the short term, will get us out of this danger zone of being at 16 while we gave him the fluids to help change it more.
And how well did that work for lowering his calcium?
It worked pretty well. His calcium came down before discharge. His calcium came down to 11, and that was over several days.
Okay, now why don't we go ahead and reveal the story about when I was on service with Mason. This patient came in after I left the service, but why don't you tell them the story about how you knew what was wrong with him when he came in?
And this will hinge on a couple of other things we did for treatment actually as well. So this man, a lot of people are asking about his past medical history, and we talked about the different types of cancer a lot. So this was a gentleman with diffuse large B-cell lymphoma. He was admitted for R-CHOP chemotherapy the first time I saw him early in the month. And his calcium was uptrending just a little bit then. And we were treating him with chemo along with high dose, which a component of which was high dose steroids. And actually, when we saw that uptrending calcium, Dr. Centaur mentioned, let's get a calcitriol level, let's get a 125 OH vitamin D level and see what it is. And it was at that time 87, the upper limit of normal being 72. And then the other studies, as expected, were normal, with a normal 25 OH vitamin D, a relatively low PTH, negative or no elevation in PTH related peptide. And then he improved somewhat with his treatment at that time, and then was readmitted with the symptoms of the abdominal pain, and this time with the calcium at 16. And so because we knew this was related to his lymphoma, and we knew this was from the increased 1-alpha hydroxylase and 125 OH vitamin D activity, we gave him high-dose steroids again, with the idea that really the only way you treat this is inhibiting the 1-alpha hydroxylase activity, and really the big thing is treating the malignancy and lymphoma. He wasn't a candidate for other chemos, but we gave him the high-dose steroids and saw somewhat of an effect in his calcium downtrending, as we mentioned. The other thing, because we didn't get quite the improvement we wanted, and we knew it might be helpful, was we actually...
Mason, time out. Let's hold on and let's make sure everybody understands the calcium before we get on to the esoteric stuff here.
All right.
Okay. So why is calcium going to work for this, and why is calcium... Because this is just like a sarcoid case at this point. So in what way do steroids help you when you have excess vitamin D? So what we're going to have to understand is the physiology of how vitamin D causes hypercalcemia. That might help us better understand the physiology behind steroids and hypercalcemia. And Sukriti and Austin are looking at me like, is this guy really asking these questions? They seem like interesting questions, don't they? Do you like the questions?
Love the questions. Don't know any of the answers, but I'm here for the learning part.
Yeah. So have you thought this through, Fernand? Did he get paged again? He might have gotten paged again. You never know with Fernand. Okay. So one of the main ways that vitamin D works is it increases absorption of calcium from the gut. And that is directly blocked by corticosteroids, glucocorticoids. That also is one of the reasons that you get osteoporosis when you're on steroids, because you're absorbing less calcium. And I think there's also something about calcium moving in and out of bones and steroids preventing that. That's what I always knew. And then what I learned from this case is it also does inhibit 1-alpha hydroxylase. And so you make less vitamin D. But long-term steroids is not a really good choice to keep anybody on, because there are a lot of side effects from high-dose steroids.
And I also think it's important in this case to understand the mechanism and what vitamin D does, and knowing that it more so affects this absorption of calcium in the gut, and less so is involved in mineral bone breakdown at the bone. And so these things that we give that affect you at the bone, like bisphosphonates, aren't going to have as good of effect as they would with some of these other types of hypercalcemia, of malignancy, where it's more about the bone breakdown. Because this is more about gut absorption, those aren't as effective, and the steroids are much more effective.
Now you're about to learn something that I learned from this case. And this became an unremarkable labs the day that Mason sent me an email to give me follow-up, because I'd seen him originally and had figured out that he had hypervitaminosis D from the lymphoma, but I had no idea what the PharmDs were going to come up with. So teach them, Mason.
So in doing some reading and discussions and all, we were trying to figure out what we could do for this man to keep his calcium down in the outpatient realm. And really, in this case, it was mostly in a palliative setting to control these symptoms. And what we did was we actually sent him home on ketoconazole. So ketoconazole, we obviously think of, right, it's odd. Yeah. We obviously think of this as,
believe me, nobody could come up with this.
Yeah.
But if you go and Google ketoconazole and hypercalcemia, right after this, you're going to see a bunch of articles about the use of ketoconazole in the hypercalcemia of sarcoidosis.
Mm-hmm.
I had never heard of it, and I love hypercalcemia, and I'd never heard of it.
So the way ketoconazole works is antifungal, is it inhibits cytochrome P450 enzymes, and in the fungus, they're involved in cell wall creation, I believe, and so it inhibits the funguses that way. But because 1-alpha hydroxylase is a cytochrome P450 enzyme, the ketoconazole also inhibits 1-alpha hydroxylase, and therefore you don't make the active vitamin D that is your problem in this hypercalcemia related to lymphoma. And so you don't resorb as much of the calcium and should be able to help control the calcium levels in these patients.
So Fernand, you're back?
Yeah, temporarily.
Temporarily. So did you catch did you catch the story? Catch up on the story?
No. So what happened after you guys treated him? It's high dose steroids and then discharge on ketoconazole because he was refractory to steroids?
No, because steroids block the calcium absorption, but it doesn't block the effect on the bone. And so you want to decrease the vitamin D level, and ketoconazole will block 1-alpha hydroxylase.
Oh, that's interesting, because I know that we use it also in weird areas. For example, in prostate cancer as an anti-androgen medication. It seems like it has a lot of off-label uses.
Yeah, it has to do with cytochrome. Say that again, Mason, for Fernand, because poor Fernand's getting called like every 3 minutes.
So the ketoconazole is a general inhibitor of cytochrome P450 enzymes. And I was saying that's how it works in funguses, and that's also how it works in inhibiting 1-alpha hydroxylase. And I did see that it's used in a few other endocrine issues and like you said, related to decreasing
Cushing's syndrome, if I'm not mistaken.
Mm-hmm. And that when we were trying to figure out what dose to do, we had a lot of discussion with the PharmDs about, what is the right dose? What do we put them on? And we went with, if I recall, the typical dose that you would for Cushing, thinking we're trying to actually inhibit an enzyme in the patient's own body. And so went with that dose for him.
So what I took out of this case is, and then I'm going to get Sukriti and Austin, who've been very, very brave to be in the wild frontier here. But this could definitely help you for next year to have thought through this. What really struck me was the fact that we noticed the hypercalcemia and made the diagnosis. So when he got readmitted, they already had the cortisol level, because the cortisol level gets sent out. It takes about a week to come back at our hospital. Mm-hmm. We had assumed that's what it was. And the intern that was working with Mason did a wonderful job, and really had a great idea of how to approach the patient, because we had been thoughtful about it ahead of time. So Sukriti, what are the two big things that you got out of this?
Uncle Bob, is it okay if I ask a question?
Oh, please.
I was just wondering, when we're talking about the mechanism of ketoconazole and how it decreases vitamin D, could we generalize this to say that any cytochrome P450 inhibitors can be used as like a therapeutic?
I don't know. I saw that both hydroxychloroquine and chloroquine have been used similarly. I don't know if it's generalizable. Did you find that out, Mason?
I do not know.
Great question.
Yeah, in theory, you would think it could work, but I don't know it practically if it works.
Yeah.
But I agree. Really good question.
To be fair, we have a lot of patients in HEMONC on a lot of antibiotics, antifungals. I've never felt they affect their calcium. I mean, it's an observation.
Yeah, I think it would. I think ketoconazole is really only going to work if it's a lymphoma. So Sukriti, what are the big things that you want to take out of this discussion?
I think one thing I learned today was just the underlying mechanisms behind hypercalcemia, even in the bucket of hypermalignancy. The squamous cell carcinoma, the PTHRP, as well as the alpha hydroxylase and the interleukins. Those were some things that that weren't very well ingrained in my mind. So that's something I'll take away and review. And the other was this novel use of ketoconazole and how there are multiple medications depending on going back to the physiology that can be used to treat hypercalcemia.
Austin, what did you get out of this?
I actually also had a question, if there's time. It's also relates to one of my fun facts that I learned today. The steroids are inhibiting the absorption of calcium is so fascinating. And I'm wondering if you're considering different strategies for his outpatient management of a hypercalcemia. Would a low calcium diet have any effect? Obviously, his calcium was crazy high, but like palliative if ketoconazole doesn't work, is that a consideration?
Definitely. If you read about this mechanism of hypercalcemia, hypervitamin D, hypercalcemia, a big part of it is, decreasing the amount of calcium in your diet is a huge part. For him, because he was a little bit of a palliative case, we didn't want him to have to feel like he had to restrict what he ate. But in general, in these patients, you definitely can counsel them on what kind of foods are low calcium and that they should eat those instead.
If I remember right, Mason, he had failed his first round of chemotherapy and radiation, and so we were at the rescue point. And so he was going to palliative care. So you really don't want to give him much calcium then. But it's a great question, Austin, and what it tells me is you totally understood what we said,
right?
And will remember it. And the fact that you asked the question means it's a higher probability that you're going to remember it. So I'm so proud of both of you for asking a question to improve your understanding of what's going on. That's a great way to learn. So what are your big take-home points, Austin?
The steroid mechanism is definitely a huge one. I'm definitely going to remember that. And the other one, I didn't know that you could send out 125 OH. So that's really interesting. And it really fits into the mechanism and helps things stick. So excited to work on it.
And Fernan, are you back to the ED or are you with us? Poor Fernan really has had a busy call night. Lindsay, most everybody knows Lindsay. She's one of the stars of CP Solvers. You've been writing everything down for us. Lindsay, what'd you get out of this one?
I think for me, really just remembering the basics of, separating out your severe hypercalcemia from just your mild or moderate hypercalcemia and how that changes your differential. And then I did not know anything about ketoconazole and this Cyto P450 and 1-alpha hydroxylase. So I thought that was just fascinating. So thanks, Mason, for teaching us all that.
Sure.
I had a wonderful time working with Mason as my resident for a period of time. And I think one of the greatest things a resident can do is send an email to their former attending and give them follow-up on a patient like this. It made me very, very happy when Mason did that. I was just smiling, and I realized that there was much to learn from this patient. Fernand, what's your big take home? What do you want everybody to remember from this? Because you see a lot of hypercalcemia as a hemonc fellow.
Yeah, probably reflex number one is when it's higher than 14, it's cancer until proven otherwise. But keep your mind open. I've seen maybe 2 cases of hyperparathyroidism that cause this. So always do your due diligence and order PTH, vitamin D, all of this. Also, mainstay of treatment, fluids, and bisphosphonates. If you want to give them 2 things, this is the mainstay of treatment. Calcitonin is just a temporizing measure. It loses its efficacy after 2 days. And always ask about intake of calcium, about Tums consumption. Like, people will not mention these medications. I've never seen somebody with milk alkali, but I think if you want to, you will only find it if you look for it. And probably the sign is when you have a bicarb that's pretty high. But if it's somewhere in the middle, you might only find it when you ask about it. And giving bisphosphonates in that case is a no, because you will be chasing hypocalcemia for weeks after that.
I've seen a couple of milk alkalis. I'd like you to finish with one point that you made in the chat about why in this patient you would choose normal saline rather than lactated ringers. We're using a lot more lactated ringers in many situations, but this patient in particular, you would use normal saline. Could you explain that?
Yeah, I know that after the studies from Vanderbilt, the tendency now is to use LR everywhere. It's not a surgeon fluid anymore, I guess. And it's a good balanced fluid for everything. But in this particular case, that's where I would lean more towards normal saline, because we know the biggest side effect of normal saline is causing a hyperchloremic acidosis, which, if it persists and it's profound due to the hyperchloremia, it can lead to vasoconstriction in the kidneys and more AKI. That's the mechanism and what was demonstrated in the Vanderbilt studies. So in this particular patient with polyuria, we have a tendency to develop alkalemia or alkalosis. And we can see that by the elevated bicarb. And I bet that if we get a urine chloride, it's going to be low. So it's chloride responsive alkalosis. To give chloride, normal saline will contain that chloride. And on the other hand, by kind of pushing the balance towards a hyperchloremic acidosis, we would be negating this or correcting this alkalosis. So why not hit 2 birds with the same stone?
Well, Fernand, thank you so much for juggling us in between an ER that just seems to really want to talk to you tonight. They must know you're a really nice guy.
Thank you. Thank you for inviting me. It's always a pleasure. I just have to go. I have an AML with 200 white blood cells.
And once again, Sukriti and Austin, y'all are stars, and very, very brave to discuss something that you've never seen before. And that's why you have to do internship and residency, so you can see all this stuff and think through it, because it's not easy. So I think that's it, Lindsay.
Sounds great. Thanks everybody for coming. Have a great Tuesday night.
Thank y'all. I enjoyed it.
Thank you, Mason.
Of course.
You like that, Sean? You'd heard it before, hadn't you?
Yeah, I'd heard it before. You can hear Nicole in the background now.
Oh, good, good. Sean, have y'all made any plans for next week?
I was trying to think about what would work out. Did you have something in mind?
Yeah, I talked to Alonzo. He was going to talk to Mohit and see if we could finish up the tachycardia.
Okay, yeah, that could be really good. The other thing I was thinking that we could do at some point, just because I think it's been a while, is like a pretty severe hyponatremia case.
So I was approached by TJ today, and he
Sean,
told me
can we see her since she's talking so much? Sorry, go ahead.
he has a great. He said he has a great hyponatremia case he wants to present, but he's on service, so January would be better for him. That sound okay, Sean and Lindsay?
Yeah, totally fine with me.
So he's
I'm just so
volunteered for that.
distracted. She's just so precious. I didn't hear anything.
Yeah. And Amar is going to present a patient that we just had who had Rigers, because I think that'll make for a good night floats. You know, you get called at 2 a.m. because the patient's having a Riger, and then what happens subsequently is actually very interesting, and it gets even more interesting. And I'm going to try to get Rachel Lee, who actually helped us with the patient, to be there and talk about how you think about different organisms and stuff. So I think we're good for next week, and then we'll have to think about the following weeks. I think she even likes you, Sean.
Just a little bit. Just has to be.
Yeah, from time to time, we have a good time together.
Yeah, that's great. Well, Lindsay, thank you, and Sean, thank you. I think that one turned out great.
Yeah, it was really good.
Yeah, it was the twist at the end on the ketoconazole. That was but look it up, and I'm telling you, it is a standard treatment in severe hypercalcemia of sarcoid. Pretty wild.
Very interesting.
Okay, y'all have a good night.
You too.
See ya.